Uh, well, thank you everybody for joining today. Thank you, Barbara and the Department of Pediatrics for inviting us to give this presentation, this symposium really on some of our work in the cardiology realm with acute COVID and MISC. Certainly some of this spans across the pediatric spectrum, but we wanted to highlight some of the things that people in our department have been doing. And so I asked a few of our fellows to share some of the work that they've been doing with regards to COVID-19 and multisystem inflammatory syndrome. So first up today, we'll have Mansi Gaitonde. Mansi is currently a fourth-year fellow with us, doing a year in non-invasive cardiac imaging. She's been at Emory for quite some time, did her residency here, and then did on for a pediatric cardiology fellowship, and then a fourth year. And prior to that, she came to us from UT Southwestern in Dallas. So Mansi, floor is yours.
All right, well, good afternoon. Thank you for having me speak today. So I'm going to be discussing the cardiac imaging findings in MISC. I don't have any disclosures. I hope that you can leave today understanding the utility of the various cardiac imaging modalities in MISC, understand the implications of these imaging findings, and apply new knowledge to current and future imaging practices with regards to MISC. So many of you are probably aware of the various iterations of the MISC protocols that we have at CHOA that are currently continuing to be reassessed and updated based on our newer understanding of the illness. So from a cardiac imaging perspective, outside of really critically ill patients with severe illness, we've theorized some frequency of repeating inpatient echoes, as well as in our outpatient clinics. And the purpose of this surveillance is to assess for known complications of ventricular dysfunction, effusions, valvular regurgitation, and coronary artery dilation. Additionally, we have recommended obtaining cardiac MRI in patients with prior dysfunction from MISC at 3 to 6 months from disease onset, though these recommendations are being revised based on our preliminary results. And there is also some consideration for long-term exercise stress testing, though this is of uncertain benefit. The ideas regarding which tests to order and at what timing are primarily extrapolated from our guidelines and clinical practices with regards to myocarditis and Kawasaki disease, but both of these have different follow-up timeframes and different testing recommendations depending on if there are residual sequelae of those illnesses and what those are. So our initial published study focused on the differences between MISC and Kawasaki disease in the acute phase of our initial subset of patients that presented in spring and early summer of 2020. We're currently assessing the long-term cardiac imaging findings in MISC to observe what happens to ventricular function, myocardial strain, and myocardial characteristics. Briefly, for those who are not cardiologists on the Zoom, just want to talk a little bit about cardiac mechanics. So myocardial fibers are oriented in a double helix spherical shape in the left ventricle. So when they contract in opposing rotations at the base and the apex, it causes a ringing action. And that results in a normal ejection fraction of 55 to 70%. We make measurements and make calculations using mathematical formulas to obtain an ejection fraction value based on two-dimensional echo measurements, or we can do volume calculations by cardiac MRI. Additionally, it's important to note that the left ventricle has a longitudinal, which is the blue, circumferential, which is the green, and radial, which is the yellow, axes by which it contracts. And unfortunately, we can't apply this geometry to the right ventricle because it has a completely different shape. Strain is a newer modality, which we're using more universally in our echo lab, at least for the assessment of the left ventricle. It's a helpful tool that can allow us to suggest subclinical left ventricular dysfunction. It also has these other clinical uses, which I've listed. Frequently, it's more of a trend that we follow. So for example, if we have a cancer patient in remission with a history of anthracycline use being screened with echo per the COG guideline, they may have a subtle decline in their strain values 6 to 12 months before they begin to manifest visual signs of decreased ejection fraction by two-dimensional imaging. And strain itself is defined as a change in the length of an object relative to its initial length. and it's a sensitive measure of contractility. So we can calculate it both at the regional and the global level, and in the 3 axes of myocardial contraction that I talked about, the longitudinal, circumferential, and radial levels. So anatomically, the myocardial fibers are arranged in a longitudinal fashion in the subendocardium. So when we talk about global longitudinal strain, we're referring to the subendocardial function. Circumferential strain is referring to the mid-myocardial function. And then radial strain looks at myocardial contraction in a short axis, but it has a lot of variability, so we often don't routinely assess this. And this video just shows how we do the speckle tracking for strain. We need to have very good 2-dimensional visualization of the heart-blood border of the left ventricle. So you really shouldn't report a number if you don't have good tracking of all the segments you see here. And the lines at the bottom relate to the left ventricular segments by color coordination, and they should be synchronous in normal contractility. So one line contracting on its own waveform, doing its own thing, is not normal, but you have to ensure that these speckles are being tracked correctly in their appropriate segments. And then we do this in 3 orthogonal planes to look at all the regional segments, but we give you a global number. And normal is more negative than -20. So this patient would have reduced strain. If we believed that all the segments were tracking, we would look at that. And we can see that there are lower values in the posterior lateral segments. So that's just a little bit of an intro to strain. And briefly, cardiac MRI is very useful for myocardial characteristics. And we can actually have very good resolution in a still patient who does not have erratic breathing. And so we can visualize coronaries quite well in these patients, as well as our routine sequences to look for edema, hyperemia, and fibrosis, which would be, excluding the coronary portion, the rest of this would be routine for a myocarditis study. So the aim of our study was to compare echo features in children diagnosed with MIS-C during 2020 with the historical control of children with Kawasaki disease to see if there were critical differences between these 2 inflammatory conditions in the acute period. So this was a retrospective data collection with, again, the MIS-C group being from March to June 2020, and the Kawasaki disease group was from 2019. We randomly selected from age, sex, and race match historical Kawasaki disease controls. The MIS-C group included previously healthy children who met criteria for MIS-C, and in the Kawasaki disease group, we included both typical and atypical Kawasaki disease. We excluded patients with significant congenital heart disease or other significant disease processes that could impact inflammatory markers, echo measurements, or could impact just the resolution of illness. So at the time, we had 14 patients and 2 were excluded just because they did not meet the inclusion criteria, and we were left with 12 patients. We matched it to 12 patients with Kawasaki disease. All of these echocardioms were de-identified and then uploaded to a vendor neutral software for a blinded analysis. So just to highlight a few of the major points on the study were that in the initial echo, you can highlight the differences here between the MIS-C and Kawasaki disease group. You see statistical differences in the ejection fraction and the global longitudinal strain, with the MIS-C group being worse. Additionally, there were higher degrees of mitral regurgitation and pleural effusions in the MIS-C group, which is a common nonspecific manifestation of many systemic inflammatory conditions when there's active inflammation in the body. In this early population, there was no differences in the blinded coronary artery dimension measurements between the groups, though later studies from other institutions may have shown a difference. And I also just want to point out the clinical course of this early group, which kind of helped us formulate some of the early protocols. So in the initial group, 2/3 of the patient presented with reduced ejection fraction and reduced strain. And at discharge, 6 of those patients had normalized their ejection fraction, but still had reduced strain at discharge. And the other patients, the 1/3 who presented with normal EF, 1 of those did have reduced strain at onset. And then 3 of the 4 did develop reduced EF and strain during their hospitalization. At the initial echo, we also found that there was a negative correlation between ejection fraction and troponin level with an R value of -0.9. The LVEF normalized in most patients by day 7 to 9 of illness. And we found that in most patients, the strain values remain reduced by discharge. So we're still doing the blinded strain analysis in follow-up from our outpatient echoes, so I can't report those values today. However, we have about 75 patients with very reassuring prelim results. There's a mean follow-up of about 49 days. So only 3 had sort of low normal ejection fraction around 55%, which is very reassuring that only 3 of the 75 were here. Everyone else was completely normal. And we had 1 patient with just slightly more than mild MR and 1 with a trivial pericardial effusion. I would say these are pretty sort of very mild findings, and in the absence of any clinical symptoms, pretty reassuring findings. We do have 1 patient with residual coronary artery dilation and 1 with residual aneurysm, but clinically are asymptomatic from that standpoint. So going forward, we're going to have to see what to do with these patients. And then our preliminary cardiac MRI findings, we have 17 patients which we've scanned, and then 1 cardiac CT, which was due to the fact that the patient had contraindications for getting an MRI. And these studies did include the 1 patient with coronary artery dilation and the 1 patient with coronary artery aneurysm. And so again, these were also very reassuring findings. We did not have any late gadolinium enhancement noted on any patient, which is what we look for myocardial fibrosis or scarring. We had 2 with borderline elevated T1 values, which is a marker for edema, but we use a hematocrit value to calculate some of these measurements for extracellular volume in the myocardium. And we had no recent hematocrit. Some of these patients are quite anemic in their initial hospitalization, and so this could be just spurious. And then 3 patients had mildly reduced EF by the volume measurements that we make on MRI. And sometimes this can be anesthesia related because it did not correlate with their echo that they had in clinic. So we have revised some follow-up protocols to be distributed soon. And it's unclear if this is more similar to KD than myocarditis, but I think that we're going to probably trend our follow-up protocols to be more similar to Kawasaki. However, have a lower threshold to be cautious in patients who really have true cardiac dysfunction, because there are rare patients who can be very critically ill from MISC from a cardiac perspective. And then the question of what to do about these rare patients who still have persistent coronary dilation and aneurysm, I think we don't know, but we do have some really strong guidelines in Kawasaki that potentially we can apply and extrapolate what we know about that to this illness. So my conclusions just for you is that various cardiac imaging modalities have been helpful to understand MISC-related cardiac illness and recovery. And our initial review of the follow-up findings appeared to be very favorable, which is good for these children. We may need to consider specialized testing for residual coronary artery dilation and aneurysm, similar to KD, which could involve stress testing for these specific patients down the road. And then there's always the question of exercise restriction and what practices should we follow, leaning towards more of a Kawasaki perspective or a myocarditis perspective, but I don't have the answer. It's just a question for you to think about. And that's what I have for you today. Thank you.
Great. Thank you very much, Mansi. That was very well done. We'll have a couple of minutes for questions if anyone has any for Mansi. I'll just add to that, she alluded to some changes we're making, and we have started making a couple of changes. In clinic, we're not going to be doing as many echoes after the 6-week period if they've been normal, just because we're not seeing that many changes. For referring for MRI, we had a very low threshold that anyone with any sort of abnormal BNP or troponin or cardiac dysfunction, anything during their MISC course was going to get referred for MRI. But yes, based on what we're seeing here and based on what we've learned from other institutions, we have talked to some others who are starting to get into the MRIs of these kids. No one really has seen a whole lot. So we have revised ours to say that referral for MRI is only going to be for children who had an EF of less than 50% at any point. It's kind of an arbitrary numbers and more in line with what some other institutions are doing. And we may revise that in the future as we continue to learn more and have bigger numbers. Are there any questions for Mansi?
Yeah, I have a question. This is very interesting, and I have to acknowledge that I don't understand very much strain. So I apologize if it's a stupid question, but strain is abnormal in other situations as well, like in sepsis. And I was wondering, since we have a lot of patients with sepsis-related echoes, is the strain findings on sepsis, which is a massive inflammatory process, different to what we see in the COVID-19 MIC situation, or do they have any similarities?
So as I said, we're kind of looking more at global strain. I think we haven't done necessarily in pediatrics looking at regional strain. And so seeing that those changes being different between a global sepsis picture versus kind of regional inflammation in MISC, I think that could be something to explore. But again, strain is very much specific to how well you image. And so there's technical factors that can impact how your values are reported. So I think as a lab in the last year or so, we've been more routinely doing strain on just function assessments. I think those are interesting questions going forward about whether there's a difference in more regional versus global between these two populations, but I don't think I know the answer to that off the bat.
Yeah, those are good points. It's definitely still a lot more to learn about strain. The clinical utility of it, not just the research on what does it do, but what's the utility of it.
I was wondering, it's only a marker of the diffuse inflammation, and may you see the same thing in the sepsis syndrome as well.
Yeah, and I just always want to emphasize that strain is more of a trend that we follow. So I always think of it as a trend rather than just saying like the number is minus 15, but think of it more as a trend.
Great.
Yeah, are you guys seeing the presenter mode?
No, we can see your actual display there, Matthew. So if you are ready, I think you can go right ahead, unless anyone else has any last questions for Mansi. Nope. Okay. Matthew.
Just to confirm.
So Matthew Dove, Matthew Dove is one of our second-year cardiology fellows now. He, previously did his residency at Vanderbilt University and went to med school at University of Mississippi. And so he's going to share some of the work that we've done that really was multidisciplinary. We had collaborators in many other departments, so we appreciate everyone for their help with this, both at CHOA and other institutions. So Matthew, why don't you go ahead and tell us about your project?
All right, good afternoon. My name is Matthew. I'm a fellow here at CHOA, and today we're going to highlight a recent study we performed looking into the hospital management of MISC. So MISC is a novel disease and overall still lacking evidence-based guidelines for the evaluation and management. And then in the absence of these guidelines, many of the hospitals across the US have been creating their own institutional protocols to help standardize the patient care. The purpose of our study was to compare and contrast the recommended management of MISC at the different US children's hospitals. And then additionally, we wanted to be able to provide a starting point for those hopeful in creating their own protocols, especially as MISC cases continue to rise across the country. To do this, we conducted a survey of US hospitals regarding their protocols for the management and evaluation of MISC. This was conducted from June 16th through July 16th. Only one response was allowed per institution, and then no direct patient data was collected. It was strictly information based on their protocols. And then the elements of this survey included hospital characteristics, the definition of MISC, evaluation, treatment, and follow-up. So we received a total of 46 responses from different children's hospitals, and 40 of those had established protocols. We excluded the other 6 from the data collection. And then, as you can see, indicated by the red and orange dots, it does seem the majority of estimated cases at this time had occurred in the Northeast, going along with the spike in COVID cases in that region as well. We received fairly even responses from both small and large children's hospitals. It was 10 of bigger hospitals and then 15 each of small and medium sized. And then the majority of the centers estimated to only have seen 1 to 5 MISC patients at the time of the survey, but there were several that were quite experienced by that time as well. In May of 2020, the CDC had released a health advisory regarding MIS-C, and they included a definition for reporting patients at that time too. The definition used was a fever of 24 hours or more, laboratory evidence of hyperinflammation, severe illness requiring hospitalization, a multi-system organ involvement of at least 2 organ systems, confirmed current or recent COVID infection either by PCR or antibody, or exposure within the last 4 weeks. And then also all that in the absence of another diagnosis. We have found that many institutions adhered to a very similar definition during the evaluation of their suspected MIS-C patients. 22 of the centers required 1 day of fever, while 15 required 3. And then additionally, all but 4 required seeing the laboratory evidence of hyperinflammation. And then the vast majority did require the 2 organ system involvement to make the diagnosis of MIS-C. Most centers were requiring either the PCR or antibody or known exposure, but I did think it was important to recognize that a few of the centers, because of their high prevalence of cases, would even forego those requirements when making their diagnosis. When it came to the initial lab work that they were doing for evaluation, most institutions did recommend a tiered approach. The initial labs that were frequently gathered included a CBC, a chemistry panel, LFTs, CRP, and ESR. And then additionally, all institutions recommended obtaining a COVID PCR with high suspicion, and then most recommended testing for antibodies as well. If part of the initial workup was concerning for MIS-C, that's kind of when the secondary lab work was recommended to be obtained. And those labs included ferritin, D-dimer, troponin, BNP, coags. And then in some centers, they were additionally requesting procalcitonin, cytokine panel, and interleukin-6. EKG and echocardiogram are also frequently listed in the first line testing. And then because many centers advocated for pursuing alternative diagnoses or co-infections, therefore they also recommended getting blood cultures, respiratory viral panels, urinalysis, and x-rays. When it comes to the consultants, infectious disease was almost universally called. About 90% of the centers listed using ID consult for all patients, and then another 8% for some patients. Cardiology, rheumatology, and hematology were also listed frequently, but those were a little more directed based on the individual patient's case. The protocols often recommended different treatments based on the severity of the case. And although there was not a uniform definition, some of the criteria that hospitals listed included degree of hyperinflammation, whether they were in the PICU or on the general wards floor, their presence of shock, cardiac involvement, or the vasoactive inotropic score. IVIG was the most widely used treatment for MIS-C, and 98% of centers listed them in their recommendations, and 60% of those recommended using IVIG regardless of the severity of the case. Many institutions also recommended a second dose of IVIG if the patient doesn't respond to the first dose within the first 36 hours. With corticosteroids, this was listed in 93% of the protocols, but most of them are reserved for the moderate and severe cases. And then additionally, aspirin was also included frequently for inpatient management, but it was also included for mild cases as well. For more of the severe cases, heparin and Lovenox was often recommended. And then additionally, anakinra and vasopressors were recommended for severe cases, albeit at a much lower rate than some of the other medications. Some of the medications that were listed infrequently included infliximab, tocilizumab, remdesivir, warfarin, and clopidogrel, and those were all reserved for more of the severe or refractory cases. And then of note, hydroxychloroquine was not listed in any of the recommendations across the US. When it came to follow-up, cardiology was the most universal consultant to follow-up as an outpatient. 39 of the 40 institutions all recommended cardiology follow-up. And then 22 of them had recommended at the 2-week time period, but all 39 had suggested seeing at least within the first month. Rheumatology and ID also followed up MIS-C patients based on the recommendations of about half of the centers. We noted that the American Heart Association Kawasaki disease guidelines were often being used to help determine the timing of the follow-up, as well as the decision on anticoagulation. Many centers were recommending at least 4 to 6 weeks of low-dose aspirin, and that was regardless of the coronary involvement. Of note, cardiac MRI was also listed in the evaluation and follow-up of cardiac dysfunction, though this was usually at the cardiologist's discretion at 22 centers. But 2 centers did recommend getting the cardiac MRI during the initial hospitalization. And then I think it's important to note that, over half of the institutions had already updated their protocols at the time of this survey. So even within a few months of creation, they had already been changing their protocol. So as knowledge and research is rapidly evolving, we expect there to be several more changes as experience and research increases. The take-home points for this research are that there is a lot of variability in the evaluation management across the country. However, there are some main common themes to take home. And so one of those is that it does take a team approach, that many of these centers are involving lots of subspecialists. The CDC definition is being most frequently used for making the diagnosis. IVIG and aspirin are the mainstays of therapy, and then steroids are commonly used in moderate or severe cases. And then the follow-up with cardiology is universal and often similar to the KD guidelines. The protocols have been changing often, and I think it's important to remember that care is often individualized as well due to the complications that arise. I'd like to thank Dr. Oster, senior author on this project, and then Dr. Jaggi and Mike Kellerman for their help, as well as all the collaborating centers. If you're interested in seeing any of the protocols these centers have been willing to publish, we have them on the online article on JPEDS. They can be reviewed.
Great, thank you very much, Matthew. Yeah, this is, as you know, we're all in interesting times and learning as we go. And I think this was a great project just to show a few things. One, that a lot of people are relying on past knowledge with KD. 2, that people were really excited when we reached out to them. Were very willing to share, and with the whole purpose of learning from each other. As Matthew said, we had 40 centers that were willing to share their protocols to be included in the supplement, which I think is just fantastic from a learning standpoint. And, as you said, a lot is changing. Just, in that survey already in the first couple of months, half had changed their protocol. And now, our institution's no exception. Many of the responses that we put on the survey would be different now, just because we learned from this. We saw what others are doing, and we've learned from our own experience. And our institution has made some updates as well, and I'm sure there may be updates to come in the future. Are there any questions for Matthew about this project, or any other bigger thoughts about where to go from here? I think certainly this is something that in the future we would want to revisit and see what people are doing as we learn more about this disease.
I think definitely, this is Preeti Jaggi, that a repeat survey would be a great idea. And I think another thing that we could also consider asking is the duration of treatment. I think our center is a bit unique in that we give a fairly short duration of corticosteroids, where other centers are doing weeks and weeks of taper of steroids. And I think actually it seems like our patients have done pretty well with many patients have done very well with a shorter dose of corticosteroids. So that would be another interesting area. I think that we weren't all thinking that much about, we were thinking more about the acute management, but I think, the follow-up is going to be a really important thing to ask about in the future.
Yeah, absolutely. And it'd be interesting to see, at least anecdotally, it seems anakinra is used a little more often with and bivalirudin also, given some of the COVID literature in adults.
Great. Any other questions for Matthew or Preeti, or anyone have any big thoughts or discussions about MISC, either here at Children's or elsewhere? Okay. So you've heard a couple of talks now about what we're seeing acutely during these kids. Mansi told a little bit of the long term. And now we're going to learn more about what are we seeing in follow-up. So changing gears a little bit, where Mansi and Matthew talked a lot about MISC. We also have been doing a lot of work in our group about clearing kids after they've had COVID-19 for athletics, particularly the role of EKG screening and coming to see us in cardiology. So Jamie Dyal and Andrew Dailey-Schwarz are going to share some data that is really hot off the press. We just finished these analyses earlier this week and submitted an abstract to ACC. So this has not been published yet, but hopefully we'll get this out very shortly. Jamie and Andrew are also second-year fellows like Matthew. Jamie did his residency at Johns Hopkins University, and before that was in med school at University of South Florida, Morsani College of Medicine. And Andrew did his residency in Houston at Baylor College of Medicine and attended med school at Wayne State. So I thank you both, gentlemen. And Jamie, I'll let you take it away.
All right, great. Thanks very much, Dr. Oster. Can everybody hear me and see my slides? All right, perfect.
Yep.
So Andrew and I are going to be talking today about ECG screening after COVID-19 infection in children. Bear with us, we're in different locations and we're going to switch our screen sharing mid-presentation, but I think we can manage that technical hurdle. So today we're going to be talking about ECG screening after COVID-19 infection. And there we go. Andrew and I have nothing to disclose. To start, we're going to give you a little bit of background about how COVID is theorized to affect the heart. And although many of you are deeply familiar with the distinction, we'll just review how COVID-19 infection is different from MISC. We're going to talk a little bit about how ECG screening can be used to identify any cardiac sequelae following COVID-19 infection. And then we'll review the methods of our study, the results that we obtained, including the results of our EKG analysis, and review some conclusions, limitations, and next steps going forward. So to start off, we have a few different proposed mechanisms for how the heart is affected during COVID-19 infection. The first and most direct is straightforward myocardial injury, in which the virus itself binds to the myocardial cells and induces myocardial injury directly. However, there are two other theories that have been proposed. As we have noted in MISC, there's pretty significant inflammation, indeed hyperinflammation, and that inflammatory process may also injure myocardium. And as we know, COVID-19 does severely affect the lungs. And if in fact a patient experiences respiratory failure and resultant hypoxemia, that anoxic injury can also cause damage to the myocardium. And when that damage occurs, we have a number of different ways of seeing that injury, including biomarkers in the lab, arrhythmias that we can see on EKG, and other ways of assessing when that injury has occurred. To clarify, we have a distinction between acute COVID infection and chronic effects long-term from following COVID infection. We're not necessarily great at detecting acute cardiac infection if we're not looking for it. And so part of what we want to do is determine when it is necessary to look for the varying acute and chronic effects of COVID. In particular, one of the effects that we're that we're concerned about is myocarditis, which we know can be effectively diagnosed by ECG. We do have other means of effectively identifying myocarditis, including on echo as well as with lab testing. But our ECG is a mainstay of diagnosis, and it's part of what we need to be keeping an eye out for after COVID infection. Let's get my screen working again. There we are. To clarify the distinction between COVID infection writ large and MIS-C, this is the definition of MIS-C as it was initially proposed and what we initially were using here at CHOA. I think all of you are fairly familiar, and I know Matthew just went through the way a lot of other institutions are defining it. For us, we have been using these definitions. A patient that is less than 21, has fever, lab evidence of inflammation, and evidence of clinically severe illness that required hospitalization with multi-system organ involvement, and no plausible alternative diagnoses, and a positive or recent SARS-CoV-2 infection by PCR antibody testing, or a known COVID-19 exposure. So that was initially how we were diagnosing it. I know we've talked about how that is evolving over time, but that was initially our thought. So for us, our question in this big milieu of COVID investigation is, should post-infection EKG screening be routinely obtained in children with a history of SARS-CoV-2 infection? More specifically, does EKG screening reveal any clinically significant cardiac sequelae of COVID infection in children? To identify those answers, we did a retrospective chart review of all patients that were referred to outpatient cardiology clinics from August 6th through October 30th. The reason we chose August 6th was that was the first day that we had a large-scale community meeting to discuss reasons and indications for referral to cardiology following COVID infection. And that was done with Dr. Oster in the presence of a number of different community pediatricians. And following that date, there were also some web meetings that were attended to try to disseminate these referral recommendations. Without getting into the nitty-gritty of that referral flowchart, this was the initial proposed flowchart for how patients ought to be referred to cardiology. And ultimately, we ended up having 253 patients that were referred for cardiac evaluation following COVID infection. In our study specifically, we wanted patients that were specifically referred to us after that meeting, had an EKG at a Sibley clinic, and we excluded any patients that were defined as having had MIS-C, and we excluded all patients with complex congenital heart disease. And in total, we ended up with 206 of those 253 patients meeting those inclusion and exclusion criteria. Andrew is going to talk a little bit about the results that we obtained from that study.
Okay, so I just grab the remote, press remote control. Is this working? I can't actually see. Okay.
Andrew, we can see the screen, but we cannot hear you that well.
Really?
Does this make it easier?
That's much better.
Okay. So you can see the screen moving. I can't.
I think I see just the outline with results highlighted.
Okay.
There you go. That worked.
Okay.
Andrew, I can move the screen if that helps.
Yeah, I think, are you still sharing your screen, buddy? I don't want to take this too long. I'm sorry, this is not ideal.
Let me
I'm controlling your screen. How do I take control and share my screen? Speaker view. How did you do that?
So
All right, so at the bottom of the screen, you should see an item that says share screen, and you can
Oh,
click
got it.
that.
Got it.
You'll be able to pull up your PowerPoint.
Okay, perfect. Got it. Share. Okay, and then I can go in here.
Yep, we can
Okay.
see the PowerPoint program, and now we can see the presentation. Good.
Okay, good. Thanks. Sorry about that. And then, so going into our results, we first have our race and ethnicity breakdown, and we do acknowledge that it is something that is entered, and it's not necessarily verifiable. But we did have a predominance of non-Hispanic white at 84%. The gender breakdown was slightly skewed at 58% for male to female. And just one other thing, I don't think we included here, but I did look at the breakdown of the clinics, because we do have a network of 23 clinics throughout the state, but 3 of them actually composed about 50%. So we have to acknowledge that there might be some skewing based on the region of Atlanta that we were covering. I think Alpharetta, Marietta, and Scottish Rite was roughly 50%. But we did have smattering of clinics from all throughout the state as well. In terms of demographics, the median age was 16 years old. We did have patients ranging from 3 to 21. You can see here, we excluded people or children who were existing patients with congenital heart disease that was unrepaired. However, if they had what we consider to be a repaired lesion or non-structural heart disease, we were able to include them. So we had patients who may have been seen in the past, but were not regular cardiology patients. Maybe they've been seen in the past for a single episode of syncope, which is very common in teenagers, or a resolved arrhythmia issue. And so very few of these, I mean, there's only 1 or 2 for each of these. So the vast majority of these are completely healthy children with no previous cardiac history. So in our breakdown of patients, which you're going to see on a future slide, you can see that there was some patients that were referred with existing cardiac symptoms from the pathway that we have. These were not exclusive, so some of these patients actually would be listed as having chest pain and fatigue. And they may have had a syncope and shortness of breath, but overall, the vast majority of the cardiac symptoms were chest pain or just a vague fatigue, malaise, that we weren't necessarily able to say is purely cardiac, but that was the reason that they were concerned and were referred by their pediatrician. So this is kind of the meat of our study. You can see at the top, there was 206 patients that met our study criteria. And so they referred to cardiology after having a COVID-19 infection and recovering, and meaning that they did not have MIS-C, that they didn't have structural heart disease, we also excluded if they were, like Jamie said, if they were seen or referred while in the hospital. So looking down the left side of here, because I'm not sure if you guys can actually see my mouse unless I use a pointer. So oops. So there was.
We can see your mouse, Andrew, when you go through.
Oh, you can? Oh, good. So there's 180 patients who were initially referred for without cardiac symptoms or concern, which means they go down the pathway where they were not seen clinically. They were only seen by the office staff and had an EKG, which was read by the cardiologist. There was some that were the cardiologist read and then would have them follow up in clinic in the future. We did have to remove those from our data points just to make sure, because it didn't make sense for them to have 2 separate data points because it's 1 individual with 2 points of contact. So they ended up in the grouping of patients that were referred for a full visit, which contributed to what ended up in the bottom right, seeing the total number of 70 that was evaluated in person by a cardiologist. But just going back up, so if they had no cardiac symptoms, they had no chest pain or syncope or concerns from the pediatrician, then they were referred for the EKG only. And of those, 136 were completely benign. They had absolutely no findings on them whatsoever that were concerning for follow-up. This did include a benign variant of sinus bradycardia for age. Generally speaking, if this was a teenager, this would be less than 60 beats per minute, and the vast majority of them were in the 50 range, and there was 1 or 2 in the 40 beats per minute range, but they were asymptomatic from this. And then from the EKG only visits, there was 10 that were referred for a clinic visit based on the EKG findings, and I think I have a future slide to show you a breakdown of them again, but it does say at the bottom what those findings were, that the cardiologist saw them and like, you know, it's just better to just be seen. What gets a little tricky is that sometimes if they were seen by their PCP, even if there weren't any concerns of a cardiac nature, maybe because they had this history of having been seen by cardiology in the past for maybe an episode of syncope, or they just felt that there was something else that they wanted to just kind of cover, they would refer them. And so if they didn't have cardiac symptoms, but they had a concern, they were actually referred for a full visit. And so that ended up being 30. That doesn't exactly follow our pathway of what was sent out to the physicians. And I think that's something that we really take into account, that it's hard to fit everyone into a box for what we're trying to do to assist our general PCPs in the community. Of those with cardiac symptoms post-COVID-19, there was 26 of them. And those are the ones that we listed on the sheet on the slide before, including chest pain, fatigue, syncope, dizziness, dyspnea, and palpitations. And so if you didn't need anything further, you were cleared via just the EKG, or you were in the group that had a clinical evaluation. There were 70 of those. And then looking at the EKGs just in more in depth, so, you know, it's hard to see that other slide, but 95% were essentially normal EKGs, and 5% had findings that aren't necessarily pathologic, but they warranted further evaluation to ensure we weren't missing something further. And, you know, all of these except for one were ultimately found to be benign. Actually, one patient was completely asymptomatic clinically, but she had significant ventricular ectopy, and so we're trying to actually have her get an MRI in the future. She actually had a normal echocardiogram at that time. From the benign EKG results, as I mentioned, the sinus bradycardia, there was 57 patients. There were some other benign findings as well, including nonspecific interventricular conduction delay and ectopic atrial rhythm. If in a non-COVID patient, if a cardiologist saw these, he or she would not normally advise follow-up or concern for these findings. Other findings, if there's a premature atrial contraction, early repolarization, single lead T-wave inversion, or non-specific T-wave flattening, very benign findings that have no real link to a pathology that would warrant further investigation. So we had shown the top part of this decision tree and in our referral process, and then if they had a normal EKG and no clinic visit, then there's no cardiology pathology identified, and so they're able to be cleared. And if they went to clinic, it ended up in two groups. Some were seen and examined and did not have an echocardiogram, and they were maybe they had a repeat EKG at a different point in time because of the screening EKG may not have been the same day as the visit. And they ended up in this group of 34, and ultimately all of those were cleared into the non-cardiology pathology with no restrictions from a cardiac standpoint. Then there were 36 patients that had an echocardiogram, and there was no concerning findings of pathology on these exams, no abnormal function, nothing that really we warranted. In fact, the one patient that we're further investigating, as I mentioned, who had an abnormal EKG, she was one, asymptomatic, and two, she had a normal echocardiogram. And I think that just points to somewhat of a limitation of these methodologies. And we can't, I think it just helps to know that the vast majority of these children are ending up being quite healthy. They just because they're clear from a cardiac pathology doesn't mean they didn't still have maybe some resolving fatigue or some benign pleuritic chest pain that was found was most of the time the chest pain, but it actually had resolved by the time they actually ended up in the cardiology clinic. And as we said before, there was a 0 out of 36 abnormal echocardiograms. You know, there's only the 205 out of 206 had no cardiac pathology, and we're not even positive that this patient does. We just want to further investigate to make sure we're not missing something. And I think just finishing up here with the limitation. And so this is a fairly limited study. Our sample size time period is from the beginning of August to the end of October. There's always the possibility that further cardiac sequelae would emerge over the longer period of time. And we were specifically looking at healthy children, so we cannot generalize to children who have existing congenital heart disease. And we did have to remove just a couple of patients from that for that reason, but we still end up with a pretty high number here. And then, we have to acknowledge that we live in a wonderfully diverse community, and our race demographics that unfortunately not represent the broader population of Atlanta. We we're seeing a lot for sports clearance in those communities. And, since younger children not necessarily being sent for sports clearance, we did have a predominance of older children. I think that's why our median age was so high at 16. We did have some younger children in the 6 to 10 age range, but it was honestly, it was less than 10. It was the vast majority were in their tweens to teens to 16s. So then conclusions here, we do know that EKG screening may not be necessary for patients that have recovered from acute COVID infection. Asymptomatic children and children without cardiac symptoms may not require evaluation by cardiologist after COVID infection. That was what we kind of concluded after looking over everything. Then next steps, we had to consider revising the referral recommendations for post-COVID ECG screening to better support the clinicians in the community. And so this is the new pathway, in keeping in mind that this isn't purely just for post-COVID, because we include the MIC pathway, which is distinct from our activities. However, we kind of end up here at the top where, if they didn't have cardiac involvement during the acute illness, and they didn't have any cardiac signs or symptoms, then we have not found anyone that would need further evaluation. They're clear for sports. Because if the PCP is examining them, they're going to notice this kind of ectopy or these symptoms like chest pain or fatigue, and those are the people that we want to see, and further evaluate. We have found no evidence of myocarditis in any of the patients that we've evaluated thus far, and yeah, that's kind of where we are at this point. We'd like to thank our research mentor, Dr. Oster and Dr. Maley, for his assistance, as well as all the Sibley Heart Center employees for everything they do to address COVID-19 in our community. That's all I got.
Great. Thank you very much, Jamie and Andrew. So that is some of our latest findings and that latest recommendation that we have. A couple of things that I will add, that the one patient that we did see that had ventricular ectopy that we are in the process of trying to get some more information from. Again, it's completely asymptomatic. Echocardiogram was normal. But she, on exam had very, very clear frequent ventricular ectopy. So even though she was sent in for EKG only, her pediatrician had sent her in just because the child had been hospitalized. It didn't appear to have examined the child before sending her in. But a pediatrician exam, based on our experience, should suffice. But then also, as Andrew mentioned, a lot of kids are sent in, even if there's no concerns. I think there's still a lot of concern in the community. We've certainly had a few schools who are requiring, their high performance athletes who have had COVID to, come in and get a full cardiac evaluation, including an echocardiogram. Although that's not typically what's recommended right now. I will add that just last week, the American Academy of Pediatrics updated their guidelines for post-COVID evaluation of children prior to clearing for sports. They agree with us in that the mild or asymptomatic cases do not need cardiology evaluation, but they did mention in their interim guidelines that those with moderate or severe COVID need to get cardiac clearance. Again, our data is kind of hot off the press. There's really nothing else out there looking at the post-COVID cardiac experience. So I would anticipate that some of those guidelines may change in the future. That being said, with the protocol that we're putting out there, we will absolutely see any child who's referred to our clinics for whatever reason, just so we can make sure that we are providing the services that the community and pediatricians want. Any questions regarding this study or our new protocol? Nope. All right, I'm not hearing any, but if you come up with any questions afterwards, please feel free to, you can email things directly to me. I'm osterm@kidsheart.com, and I can forward any questions you have to our presenters today. But thank you all very much, and have a wonderful holiday.